Good afternoon, panelists and viewing audience. Thank you for attending our webinar entitled Diabetes Awareness in Trinidad and Tobago. This webinar is hosted under the auspices of Professor Prakesh Prasad, Vice President of Research, Academic and Student Affairs and Acting President of the University of Trinidad and Tobago. I am Dr. Samantha Glasgow, Associate Professional in the Health Sciences Unit at the University of Trinidad and Tobago, and it brings me great pleasure to be your moderator for this afternoon's proceedings. I wish to acknowledge our panelists, the esteemed Professor Vijay Narayan Singh, the accomplished Dr. Varma Rambaran, and the distinguished Mr. Andrew Danu. Before we begin, I would like to inform you of our general housekeeping rules and format for this afternoon's event. Firstly, the panelists will all share their presentations, after which they will be invited to make additional comments. During these discussions, YouTube viewers are encouraged to use the comments field for sending questions. Please indicate the panelist to whom the question is directed. At the end of the presentations and conversation among our panelists, I will pose your questions to the indicated panelist. I now present to you our first speaker. Our first presenter for the afternoon will be none other than Professor Vijay Narayan Singh, Professor Emeritus of Surgery at the Department of Clinical Surgical Services at the University of the West Indies, St. Augustine. Professor Narayan Singh graduated from the St. Thomas Hospital Medical College, London, with his Bachelor of Science degree in Anatomy with first-class honors, and received a distinction in surgery from the University of the West Indies when he completed his Bachelor of Medicine, Bachelor of Surgery degree. Among his other academic qualifications, he was awarded the Honorary Fellowship of the American College of Surgeons in November 2019, and became the first Trinidadian to be granted this distinction. As an accredited vascular surgeon, Professor Narayan Singh has contributed to national development in vascular surgery, renal transplantation, and amputee rehabilitation. He has also served communities through his voluntary work, providing and fitting prostheses for amputees. In academia, he serves as editor-in-chief and reviewer for several medical and surgical journals, has co-authored 4 books, and has published approximately 20 articles during this year alone. His most recent publication this month is a study entitled The Use of Autologous Platelet-Rich Plasma as an Adjunct for Chronically Infected Wounds in the Orthopedic Patient, a Case Report of First Clinical Experience. This evening, Professor Narayan Singh will present on the diabetic foot. Ladies and gentlemen, it gives me great pleasure to introduce Professor Vijay Narayan Singh.
Thank you very much, Dr. Glasgow. Ready. I'm not seeing my PowerPoint. I'm speaking on the diabetic foot, which, as we shall see, is in fact a national disaster. It's also a big Caribbean problem. In Trinidad, we lose about 500 limbs per year. That's more than 1 per day, and I'm talking about major amputations above or below the knee. About 15 to 20% of these die in hospital, and then another 25% would die within a year. So it is both a limb-threatening and a life-threatening disease. Imagine 40% of these patients would be dead in a year. This is what it looks like, an above knee and a below knee amputation. Severe disability associated with these. The other problem is that this is a very expensive business. It is estimated that it costs about $600 million per year to manage diabetic feet in Trinidad and Tobago. And this study, which we did, was only related to in-hospital patients in Trinidad, not the outpatients, not the ones that are managed in the health centers and by the general practitioners, etc. That's additional cost. This cost of about 200,000 TT dollars per patient is fairly standard, as you can see, worldwide. We also have another problem. In Trinidad and Tobago, people use home remedies for a considerable time before coming to hospital. They use soft candle, honey, aloe vera, wonder of the world, etc. And our study, this particular one, indicated that it costs about $70,000 more. So this would cost $270,000 per patient if they use home remedies before. They also are more likely to lose limbs, have more operations and longer hospitalization. The commonest cause of limb loss in Trinidad and Tobago among diabetics is infection. That accounts for about, as you can see here, about 87%. About 13% are pure ischemia, meaning poor blood supply. A lot of the sepsis is related to diabetic foot trauma. About 60% in Trinidad of the septic feet are directly related to trauma, and a study out of Barbados, 80%. So trauma is a major precipitating factor in amputation of lower limbs. We also have osteoarthropathy, where the bones start to become damaged. And here you can see the deformity of a diabetic foot with advanced late diabetes. And you can see ulceration at the lower part here and ulceration at the tip of the toe because of the anatomic abnormality and these areas hitting the ground. And you can see here on X-ray extensive destruction of bone and joints. This is called osteoarthropathy. There's another case of osteoarthropathy looking a little different, but you can see the difference between this limb and this limb. He's diabetic for 25 years. This is swollen, warm, discolored. And this limb is totally insensate. You can stick a nail through this and the patient wouldn't feel it. And when you x-ray that foot, this is a normal foot, this is his other foot, a normal arch. And look here, the bone is completely collapsed here and the foot is flat. And all the bone here is destroyed, as you can see here compared to here. Diabetic osteoarthropathy is a big problem. Here you can see the bones are destroyed and dislocated compared to the normal side. Another case here is where you get infection in the bone. Here is a person who has infected toe, painless, completely painless. They're insensate. And he did not know that he had actually fractured his toe. Here's a fracture. And it has broken through the skin. And this is infection now in the bone and joint. This toe is not salvageable. But the patient presents late because they have no pain. This is another deceptive problem with the diabetic foot. Here, this guy has a gangrenous toe. And that looks like his only problem. But even with under normal skin, this is normal skin, there is rotting flesh. So I always liken this onto a zabuka, where the skin looks normal and you cut it open and it's rotten. And the decay or the necrosis or the gangrene is always more extensive on the inside than appears on the outside. So it's easy to underestimate the degree of damage. This is the same patient, gangrene going all the way up here, and you can see pus on the side here oozing out. And one had to clean all this out in order to salvage his foot. Yet the skin above it looks quite normal. Another case, infected toe in the web space between the third and fourth toes, and the rest here looks pretty normal. But when you look at it, that looks perfectly normal. But when we cut that open, it is rotten all under there. So it's easy to underestimate this, and therefore to go and clean only what appears to be the affected area and leave back a lot of gangrenous tissue, which is why patients lose their feet. Even the surgeon going in doesn't know how bad it is until he goes in. This is a common other problem. This is a neuropathic foot with no sensation, where there's a little deformity that ensures that this toe is hitting the ground where the patient walks before the others. So this gets more pressure on it. And this is an ulcer that's been there for 16 months, 1 year and 4 months. When we clean this out, we've got to do a tenotomy to readjust the flexion of this toe so it doesn't hit the ground as hard. And when we do that, this is the same patient only 20 days after, with it completely healed. You can see this cut we made here. And this was going on for a considerable time before. You see, she can bend these toes, but she can't bend this because we have stopped the flexion. Another simple thing, this is going on for 8 months, this ulcer here. We do a tenotomy, we straighten out the toe, and within 10 days, it's cured. Another example of how deceptive this is, this patient just has a gangrenous heel, but it's so gangrenous, it's involving all the bones here, that she had agreed, in fact, for us to cut off her leg. So we say we'll cut it off here, below the knee, in nice, healthy tissue. Then when you go below the knee, look at how that infection is totally unpredictable looking at this foot from outside. And that's why one has to be very vigilant about diagnosing. First of all, it's very difficult to diagnose this, diagnosing the extent of it and treating it appropriately. Another simple thing, a patient here got a little stick with, not sure whether it was a nail or a thorn or something, but had this and kept it going for a couple of weeks, and then found that the foot was swelling. And this infection extended to the top of to the dorsum of the foot. And here's pus on the dorsum from that little stick in the sole of the foot. So the spread is rapid and extensive, and one has to be very cognizant of this in diagnosing and treating the diabetic foot. Here's another example of a patient who had lost 2 toes previously, injured the foot while walking here. And of course, one can see there's some color change here. So but one doesn't, so that's cleaned out where there's color change. But look at this. This is a perfectly normal area, no swelling, no discoloration. But when you cut that open, all the flesh below there is dead. So again, this is an explanation of why we lose these feet. It's always far more extensive on the inside than you can tell on the outside. And that's why I always call it the rotten zabuka syndrome. You know, a zabuka, you see the skin looking nice here, and you cut it open and it's quite rotten on the inside. This is a patient who had an injury to the sole of the foot. Again, painless, got shook, as we say, not sure with what, and left it, keep dressing it and cleaning it, putting powder, as you can see, antibiotic powder, for 10 days, and then noticed that the top of the foot, the dorsum, started to deteriorate, and then he turns up at hospital. And when we see infections going from the sole of the foot to the dorsum, we must x-ray because there's something mischievous going on in there. And here he has a piece of steel in his foot that he doesn't know about and doesn't feel pain. So that's another problem we have. So when we x-ray, that's one thing we may see. The other thing we may see is here's another fellow who got stuck in his foot here, but this is 4 weeks later, and we got all this discoloration. But he also got discoloration on the dorsum. Again, we should x-ray this. And when we x-ray it, different problem. You can see the bone here is gone compared to the equivalent on the other side. That's extensive sepsis in the bone, something called osteomyelitis. This will never cure until the dead bone is removed. Here is dead bone being removed, and after removal of the bone, 4 weeks later, he's healing up very nicely. So it's very important to diagnose it and treat specifically what the particular problem is. Here's another very strange case. This is a fellow who has had this ulcer for 2 months and it's not healing, and he's putting all sorts of things on it. And we couldn't figure out why. And then we say, let's look at his footwear. This is a slipper. This is a piece of bone stuck in his slipper here, which you can see here after we removed it. And he's walking on this bone cutting into his foot. and he has no sensation, so he doesn't know that that is there. And this is another common problem. If they are being injured by their footwear, they will not feel it. This is a lady who is walking. When each of us, you know, if you're walking with a shoe, your foot tends to slide forward. In a normal person, we will feel the sensation of the foot sliding forward. But in this patient, the patient does not feel this insensate sole. So the foot slides forward and she's walking on the tip of her toes outside of the slipper and then gets an ulcer here. So we have to look at the footwear as well carefully when dealing with the diabetic foot. Here's another interesting slipper problem. Again, the foot sliding forward. This patient got a new slipper for Christmas, and he's wearing his slipper, and after 4 days noticed there was some blood, and this slipper was slicing into the web space between the first and second toes. So that's the cause of, so we have to look at these and not just treat the foot, because then the patient will come back with further problems. He had to lose his toe, in fact, because his infection is so bad. Now, you can't think that there's any footwear that will produce damage like this in the front here, and then down here, and then on the back here. And then when you look at his other foot, he has injuries here as well. This is a very strange pattern of injury. And this is in fact due to rat bites. This is rat teeth prints here. Rats love the diabetic foot because it's sweet and it has no sensation, so they'll feed on the foot while you're sleeping. And these patients should sleep, if they have a rat problem, they should sleep with shoes to prevent that problem. The other injury you can get is with hot water. A diabetic should not put their foot in even warm water because they can't judge the temperature and they can burn their feet without realizing. This is a very common injury. The other injury is walking on a hot surface. Here is hot galvanized. This guy is fixing his roof and he's walking on a real hot roof and not realizing that it's hot and burning away his feet. There's a problem with no sensation. We also have people, and we publish this in the Lancet, people who got stuck with a thumbtack and they walk around with this thumbtack in their feet and not know, and they can hear this ticking sound when they walk, but there's nothing to feel. And then finally they figure out, well, it's something in their foot. The other form of injury we see is, this is a bandage injury. Here, the bandage is too tight and it denudes the foot here. I will run through more quickly. Here's a patient on a treadmill and the treadmill is burning through the foot. Here's somebody cut with a tile and it's always far more extensive than it appears. And here's 10 days later. When we open it, there you can see pieces of tile, pieces of dirt and tile coming out in floating pus. And this is after we clean it up. So that's sepsis, that's injury. I'm just going straight onto blood flow now, which will be the end of my presentation. Notice these feet, where the flow is impaired, look very different. They look dry, shrunken, shriveled. They're not getting blood flow. They're cooler, they have no pulses. And we have various ways we can measure it. Here we can measure the flow. This is a normal waveform, this is an abnormal waveform. We can measure it. This whole right lower limb is worse than this left lower limb. We can measure the pressures and so on. We can do arteriograms where we look at the blood flow in the brain. And here you can see this main blood vessel here coming out of the abdomen into the thigh is blocked. And we can bridge that with a graft, as we do here. Here's a graft. This is one of the kinds of grafts we can use to bridge that gap and restore the flow. Similarly here, this is in the leg now. This is the groin. This is the hip joint here. And the blood vessel is coming out of the abdomen. And here it's blocked. It doesn't go all the way down like it should. And then it reconstitutes just above the knee. So we need to jump a graft from the groin to the knee. And here we are, jumping from the groin to the knee using a prosthetic graft to restore blood flow to the leg. Here is somebody who has an ulcer of the toe undergoing early gangrene. When we do the x-ray, the arteriogram, we can see the blood is coming all the way down, blood flow great down to the knee. This is the knee here. And as we hit below the knee, it's gone. So It's blocked there. And then it reconstitutes here just by the ankle. So we have to jump a bypass from there down to the ankle, which is what we do from just below the knee there down to the ankle, restore the blood flow. And a few weeks later, she's healed. And this is another close to the end now, non-healing ulcer of the heel, no pulses, diabetic for 15 years. Arteriogram, again, you see the, you see the blood vessel coming all the way down. And once we go below the knee, it's blocked here. And then it reconstitutes a little lower down. So we need a shorter graft from here to here. There's a short graft from just below the knee to about mid-leg. New graft and healed after about 8 weeks. So that's essentially my message. That there are many aspects of this thing. There's a very short time to speak, but that's what I have to say. These are the instructions we tell patients to take care of their feet. Thank you very much.
Thank you, Professor Federer, for bringing to light the cost associated with diabetes treatment and the vivid impact of diabetes on patients' feet, particularly the importance of proper diagnosis and treatment. I'm sure our viewers would like to know more about your presentation and work. And so I encourage the audience to submit your questions and comments for the Q&A portion at the end of our webinar. I now turn your attention to our second presenter, Dr. Varma Rambaran. Dr. Rambaran is an associate professor at the University of Trinidad and Tobago. He holds a PhD in inorganic chemistry and has a piqued interest in the behavior of certain coordination complexes in biological systems. More specifically, his ongoing project at the UTT focuses on the evaluation of the anti-diabetic activities of 3 novel Vanadium complexes. Based on the novelty and progress of his work, the UTT was recently awarded the US patent. This now gives greater promise and hope for his test compounds to be taken into human trials. This afternoon, Dr. Rambaran will present on Vanadium Insulin Mimetics, methods of preparation and methods for treatment of diabetes. Viewership, I am delighted to welcome Dr. Varma Rambaran.
Thank you very much, Dr. Glasgow. Members of the viewing public, pleasant good afternoon to you all. And I'd like to thank the University of Trinidad and Tobago for giving me this opportunity to discuss my work and sensitize you, the public, on the fantastic types of research that UTT is allowing. And that's not just my projects, but similar projects. And we will encourage the members of the public as well. If you need to know more, you want to know more, you can always come and speak with us and get involved as much as possible, because this is our national university. So my project, as Dr. Glasgow would have said, is entitled Vanadium Insulin Mimetics, Methods of Preparation and Methods of Treatment of Diabetes. And as she would have told you already, we were granted a US patent. 2 weeks ago, we got the notice of allowance from the USPTO, and I'll talk a bit more on that later on in the presentation. So the objectives of this project is to furnish a family of novel drugs that will be both pharmacologically efficient and safe when used as therapeutic agents for diabetes therapy. It is divided into 2 categories or 2 components based on the availability of material and facilities for the successful conduct of these experiments. The first of these categories will be the synthesis and characterization of the drugs. In this case, the vanadium coordinated complexes. I'll be discussing 2 of them, PDOV and PIDOV. And I am working on these right now at my lab in UTT. And I'm assisted, thankfully, by the chemistry department at UWI, because they possess the necessary special characterization instruments that I need to confirm the structure and the purity of my compounds. And the second step, because we lack the laboratory environment and the knowledge, the expertise to conduct these studies, I have confirmed, and UTT has recently gone into a memorandum of understanding. We have signed a memorandum of understanding with the Rajiv Gandhi Center of Biotechnology in India. And I will be going there to conduct the next phase of studies there, the in vivo dose response studies with the drug on a population of diabetic mice. Now, before I go into discussing the details of my project, I think it is very important that we understand properly the relationship between insulin and diabetes. Now, while it may be common knowledge that there are arguably three types of diabetes, type 1, type 2, and gestational, not many people understand what really is the role of insulin and how important insulin is to our endocrine system, and how it is possible that we can survive without actually using insulin. So with my discussions with people who are diabetic, the average person out in public, I will ask them, so what are you, type 1, type 2? What drugs do you take? What commercially available drugs you will take? And do you know what insulin really does? And I get two misconceived notions of what insulin, the actions of insulin. The first of them is that they believe that insulin binds to glucose and physically transports it across cell membranes as a carrier protein. The second misconception is that insulin has enzymic activity and it binds to glucose and breaks it down to release energy as we would need it. But the truth and the fact is that insulin is a hormone and it has signaling action rather than enzymic or carrier functions. So to understand the actual function of insulin, and then if you can understand the function of insulin, then we can work around finding a substitute for insulin. We must now look at the insulin transduction pathway. Now, in all of our cells, we have structures called receptors. And for this particular example, we have this blue structure here. This is the insulin receptor. The insulin receptor is divided into two components. We have an extracellular alpha unit, and we have an intracellular beta unit. The extracellular alpha unit is the site where insulin will bind. So once there's glucose, there's an excess of glucose or the presence of glucose in the body, and the pancreatic beta cells have detected it, it is going to secrete the hormone insulin, and then the insulin molecule will come and sit here and create or induce an allosteric change. This in turn triggers an intracellular modulation, which causes what we term as a phosphorylation interaction or reaction. This now directly activates the key player in the insulin transduction pathway, which is the IRTK, also known as the insulin receptor tyrosine kinase. And I wouldn't bother to go into the details of all the different types of proteins, but once the IRTK has been recruited, it then stimulates, like a domino effect, a series of proteins to in turn become phosphorylated, which results now in this final structure. This is a Glut4 vesicle. It's simply a channel protein. And the Glut4 vesicle is going to now migrate to the cell membrane. And then at this point, it's going to allow the glucose to enter our cells. So having understood this, now we can understand then in the case of type 1 diabetes, where there's not enough insulin or no insulin being secreted, that now none of these intracellular pathways or none of the intracellular pathways that I discussed here can take place. Or in the case of insulin desensitization, like there's this plant that that some of us know as the mimosa. There's when you touch the leaf, it closes, right? So there's a state called tachyphalanxis, and tachyphalanxis refers to a desensitization of receptors. And in the presence of insulin, even though insulin may be present, when it binds to the alpha unit, it fails to trigger any sort of allosteric modulation. And therefore, insulin, the use of insulin is obsolete. Now, having understood the problem, we can look for a solution. We will now introduce this area of research that I am in. These complexes called insulin mimetics have the ability to trigger the insulin tyrosine kinase on their own, the beta unit, without having to go through the alpha unit. It also has a secondary effect by binding to the negative receptor, the negative protein, PTP1B, which now is usually results or is usually recruited when there's too much glucose entering and there's a case now of hypoglycemia. And the body now needs to say, okay, slow down. Too much now glucose is coming in. We need to shut off the channels. So it's going to recruit the PTP1B and it's going to shut this down. But in the case now of hypoglycemia, we want to ensure that as much glucose enters the body. So vanadium, in this case here, the +4 state, the vanadium ion, has been known to bind and inhibit this particular protein. So the channels are kept open for a longer period of time. Now, as fantastic as these molecules may seem, right, this work has been going on for quite a while. These are some examples of inorganic complexes that have been put forward by researchers in different parts of the world. This one in particular, B-of, was put forward by Professor John McNeil and Professor Chris Orvig from the University of British Columbia. And it reached as far as phase 2 human trials before being pulled off the shelf. Common to all of these complexes, you can see, is the vanadium ion, the vanadil ion. This is V here, all of them. And different will be these organic structures that chelate or bind to these metal ions. So it is clear then that it is the synergistic, this is why I have this yin and yang GIF picture running here. It is the synergistic relationship between the vanadil ion and the organic moieties that allows these unique displays of biological, desirable biological effects to occur. So now comes in the case with me. While many of these researchers started to give up hope on these complexes, reason being their shortcoming of vanadium is that if the ligand does not bind properly to the metal, upon absorption into the body, it dissociates. And the vanadium ion then starts to accumulate and becomes toxic. So many people started to fear this. And they said, well, it's a lost cause. You know, it doesn't make sense pursuing this area. But at the time when everyone started to leave this area of research, I was introduced to it. So I came into this area when my competition throughout the world was actually little to none. And during my postdoc, I was introduced to this particular ligand, pyridine diacetic acid. And through my experiments, I was able to successfully synthesize this compound called PDOV, right? This is the structure here. So from my discussions from the previous slide, if you didn't grasp the idea, you can picture, we can jest and say that, you know, like in those Indian Bollywood movies, Shah Rukh Khan has always co-starred with so many Indian actresses, but out of all Indian actresses that he claimed to have co-starred with, everyone argues that he was always destined to be with Kajol. Well, we can therefore then say that from the unique relationship that my PDA ligand had with the vanadium ion, we started getting very unique and unexpected results in terms of its glucose lowering capabilities. And this then started to blaze new trails, and we started getting very excited when these unexpected results started coming, and this led to us filing this patent on this particular drug. So this here is the crystal structure of PDOV. And as you can see here, earlier this year, this data will be published in a very prominent international journal, Inorganic Complexes, as well then as the data went forward for filing for the US patent. So pictures speak louder than words. So let me show you exactly how well PDOV actually worked. In a population of 36 diabetic rats, we administered the drug orally. And here we can actually see the control starting, obviously it was non-diabetic, so the control was under 100 milligrams per DL. And we ran the experiment for 90 days. The rats that were made diabetic, we kept one untreated. This is the STZ rat here. And the remaining two, we administered PDOV at a concentration of 100 milligram per kilogram body weight and 200 milligram per kilogram body weight. And as you can see here, by day 30, within 1 month, in a dosage regime of 1 in every 5 days, right, we consistently started to see a drop in the glucose. And this is very, very attractive. It was very unexpected, because many drugs right now in the market, like metformin, you have the diamicron, all of these things, patients are stuck with a regime of 1 a day, probably 2 or 3 times a day. Now you actually have an opportunity to take a drug 1 in every 5 days. And the sustained effect of this drug, as the results could have, as you can see, was outstanding. Further to this, obviously, we just can't be testing the glucose alone. We looked at the relative glycogen levels. Now, glycogen is an indicator of the liver's health, right? It shows the ability of insulin, to convert the glucose to now a stored form in the liver as glycogen. And as you can see here, with respect to the control, we had considerable or very similar concentrations of glycogen being created relative to that of the untreated rat. We can compare as well the relative blood urea nitrogen levels, and relative to the untreated rat, we actually see a lower level of the BUN, which could be ascribed to relatively good kidney health, as well as relative serum creatine levels. And at between 100 to 200 milligram per kilogram, which was our target doses, we actually saw that it was well or very close to the flagged concentration of creatinine. The next compound that I am presently working on, right, because I'm trying to stay within my 15-minute presentation period, is PITOV. Now, what makes this compound very unique is that this particular ligand is able now to bridge 2 vanadium ions. And it is my proposal that, because I recognize that vanadium is the active ion, this particular compound may very well be, and I use the word may very well be, more potent. So it will have the benefit of the ligand keeping or chelating the ion in a stable form and bringing it into the cell. And when it dissociates finally to bind with the IRTK or the PTP1B, it is going to do so at a lower concentration of the drug, because it is going to be double the effect in terms of the vanadium ion. So, as I said, on the 5th of November, it was actually the day before my birthday. I may have gotten one of my best birthday gifts ever, right? Our patent attorney called me and she said, Barma, we have to have a little chat. And when she did that, my heart almost jumped out of my chest because I thought, oh my God, like we didn't get through with this. But she had a very solemn face, and when we met each other on FaceTime, and then she broke into a very broad smile and she said, congratulations, this is a first for UTT. She's so proud of the work. And the patent attorney, the examiner, sorry, gave comments that the work was solid and there was no sort of contradictions or rejections with our application. So it is something that UTT should be very proud of, and us as a nation, because this is actually the first, I believe it's the first drug application patent from our country, and one of the first in almost 50 years in terms of a US patent from our country. So this was actually good for UTT. Now, as I mentioned, the future work, this is now going to take me into India. Hopefully, unfortunately, because of COVID, the international borders are closed, but I expect I should be able to leave the country sometime in January. I'll be going to the RGCD. And next year, what we're going to look at now is going to be the pharmacokinetics of the drug. So we are going to administer the drug to healthy mice, and we're going to look now at the toxicity and determine the toxicity and effective doses of the drug, right? And in terms of its ability for excretion and its storage in the different compartments in the subject's organs. In year 2, we are looking now at the introduction of the drug in a special genetic strain of mouse. It's called DBDB mice. It's and this is now where we're going to be looking for funding, because at this point here, we are looking to confirm that the drug is actually properly effective in this type of diabetic model. So if this works out, it will pave the way now for us sending in an application to start our human trials. And finally, in year 3, it's a 3-year study, then we'll be looking at the blood assays and looking for the expressions of the Glut4 receptors and the PKA and AKT proteins. Now, the question is, why DBDB mice? I just want to slip the slide in. People would ask what especially is, why the specific mouse, and why did I claim it to be so expensive? Well, this is a special strain of mouse that has been bred in the US. This particular university has the rights for the special breeding. And these mice are leptin resistant. Now, our appetite is governed by ghrelin, which is our hunger appetite, and then leptin, which is our satiety hormone that basically tells us, okay, our belly is full, you can stop eating now. But if now there's a leptin resistance, the mouse basically thinks that, well, it's an open buffet. I can keep eating and eating and eating. And then it becomes what we consider to be macrophagous. It just keeps gaining weight. And once it starts gaining weight, as one of the symptoms for insulin resistance, where the hormone insulin now cannot reach the receptor, the rat therefore can be safely classified as type 2 diabetic. So this will be the perfect model now to test the drug and see how well we can control not only the insulin, but also reduce its fat. Because vanadium as well has been known to induce lipolysis as well. Okay, so at this point, I thank you all for your attention, and I will hand you over now to Dr. Glasgow.
Thank you, Dr. Rambaran, for shedding light on the importance of insulin to the endocrine system, how it works, and of course, on your work on the effectiveness of a substitute for insulin, namely vanadium. I also congratulate you and the UTT by extension on your recent patent, and I wish you the very best in your further studies in India. So ladies and gentlemen, again, I remind you to keep your questions coming in for Dr. Rambaran and Professor Narain Singh. And now we turn to our final presenter, Mr. Andrew Danu. Mr. Andrew Danu is the president of the Diabetes Association of Trinidad and Tobago. He holds a PhD. He is a PhD candidate in clinical biochemistry and diabetes research, and is also a lecturer and teaching assistant in biochemistry. After graduating with his bachelor degree with first-class honors, Mr. Danu worked as a project coordinator with the Johns Hopkins Medicine International under the Trinidad and Tobago Health Sciences Initiative, an initiative led by the University of Trinidad and Tobago. Although the youngest member on the board of the Diabetes Association, he has spearheaded several national diabetes screening and education projects, including the Diabetes Association of Trinidad and Tobago Expo in 2017, National Primary Schools Diabetes Quiz and Cooking Competitions. His PhD work involves the investigation of novel non-invasive methods of diabetes screening and testing. He's also an advocate for health and fitness and is working on numerous intervention programs geared towards overweight children and their parents through dietary and activity modification. Tonight, I am enthused to present to you Mr. Andrew Danu.
Thank you, Dr. Glasgow. Thank you to the University of West Indies for University of Trinidad and Tobago for putting together this event. And of course, thank you to Professor Narayan Singh and Dr. Rambaran for presenting, to Professor Narayan Singh for presenting the consequences of diabetes, and also for Dr. Rambaran for presenting the promise that we have in Trinidad and Tobago of better drugs and better treatment. And of course, at the Diabetes Association, we're very happy to see both, in that we need to work on the problems that we are facing, and of course the problems are huge, but also the promise that we are seeing that of better treatment for people with diabetes that brings joy to our hearts. So I am here to present a little bit about the work of the Diabetes Association, especially because this is Diabetes Awareness Month. Let me just share my screen. So as this month is Diabetes Awareness Month, and the Diabetes Association has kind of taken the lead to do a lot of activities throughout the month, and of course focused around World Diabetes Day, which was celebrated on the 14th of November. I'm going to talk a little bit about what we have done, what we are doing, and how the viewers can get help from the association, and how we can work with other partners like the University of Trinidad and Tobago to do the work that you all are doing, and to partner with you all. So the association has been around for probably about 30 years. I've been the president of the organization for the last 2.5. And to date, we have about 5,500 members around the country and even around the world. Although we just have about 2 employees, many of us are volunteers. So we do have hundreds of volunteers that work with the association, myself being one of them, and the entire board being volunteers in the organization. So we do need help, and we are asking persons to reach out to us, because of course there's lots of work to be done, and we are the ones who are going to facilitate that. We're the ones who assist the public health system, or want to assist the public health system once we are able to, once we have the facilities to. The organization is based on 3 pillars. So we have 3 major reasons why we do the work that we do. So the first, of course, is education. Education for persons living with diabetes, so that they can take better care of themselves. Education for persons affected by diabetes, so that they can prevent, or we could delay or prevent the progression of diabetes. And education of persons who may be at risk. So the Diabetes Association has been doing quite a lot of research projects, quite a lot of education projects, and I'll mention a few of them that we have touched on for the month. The association is also big in advocacy. So advocacy is one of our major pillars. And of course, we are the organization which would reach out to persons who do need it. And of course, if people do need help, then we encourage them to reach out to us, call us, and we try our very best to assist in any way that we can. So that's one of the principles of the association as well, and we have been doing that for quite a long time. And of course, research is also a part of the organization, because as I said, we do partner with organizations. We do partner with the University of Trinidad and Tobago, the University of the West Indies, and international universities and institutions to do those projects that we need to, because of course, it's very interesting, and it's very, I am very personally happy that I'm seeing Dr. Rambaran doing this type of work in Trinidad and Tobago. And with my work with Hopkins, the reason why Hopkins came down to Trinidad and Tobago to do this type of work is because nobody was really getting this type of information, and they describe Trinidad as a gold mine for research, in that there's so many questions to be answered. Well, we are the best ones to answer those. So the Diabetes Association has been doing research projects, because of course we need to know things like the prevalence of diabetes. What is the impact? What is the prevalence? And we have been championing that for the last few years, and we are going to push forward even more in the future. The organization is spread throughout the country. Our head office is based in Shogunas. We do have 20 branches around the country. Those are support groups where we have members who are persons living with diabetes, clinicians, family members, persons living with diabetes, and they would do activities in their community. So they would do educational activities and screening, and have support group meetings. And of course, as I said, we have 20 now, but we are planning to expand and have even more, so we can reach even more communities. So that's the reach that we have in Trinidad and Tobago. And as I told you, this month is Diabetes Awareness Month. And November every year we would have planned activities, and we did start to plan activities since the end of last November in 2019. But of course, in February we had to change all of these plans. So we had to reassess and readjust everything that we were doing, because by the very nature of the organization, we are social in that we have to meet people to do testing, and we have to meet people to educate. So we've now readjusted, and what we first thought of as a as a disadvantage has come up to be opportunity for us, because now we've been able to switch to more virtual platforms where we were able to reach even more persons than we have ever thought of reaching. So we would have planned out an entire month of activities, most of which were virtual. The first activity I'm going to talk about quickly was the Carlton Phillip Diabetes webinar, which we had this past Sunday. Of course, this replaces the Diabetes Symposium, which we usually have every year, and we would have hundreds of persons coming in. But this time we had 500 persons attending our webinar on Sunday, and a huge accomplishment. That was just on Zoom, and of course, Facebook, we had thousands more looking on at some point in time. We're able to reach persons, and the theme for this month is diabetes and the nurse. Of course, every year the International Diabetes Federation would choose a theme. This year, of course, we focus on the nurse because it is the International Day of the Nurse, and how fitting it is with all of the, with of course the strains that is put on health systems by COVID-19. We now appreciate even more the importance of the nurse. So we want to highlight the importance of the nurse in diabetes care. So we want to show that the nurses do make the difference in diabetes care. So this was one of the events that we did have this Saturday, and persons could still view it. You could go on our Facebook page and you could view the recording of the event that we did have. Another one of our activities that we would normally have every year would be our 5K event, because we want to activate people, we want to work people and encourage persons who typically would not be involved in the association, and sensitize them. So we normally have our 5K, and last year we would have had about 1,000 persons. This year we were planning to have 3,000, but again we had to cancel that. So we just had an activity called the Challenges, where we wanted to get persons involved on social media, where they had to submit pictures after they do activity challenges and cooking challenges, and we would have given them prizes, and that's still going on. So you could still go on our pages and you could see that. But of course, we were able to activate, we were able to engage thousands of persons by that. And of course, engaging them meaning bringing them to our page, where they can now access more diabetes information. Of course, as I said, the organization is charity-based, so this is just a plug for what we are doing. One of the things that we are doing this month is a charity telethon. The date is wrong there. It's actually now December 11th, and we're hoping that persons do support us, because we do need support to refurbish our building in Shogunas, and to add to our education funds. because of course everything that we do comes from the support of persons. One of the activities that we are most proud of is the development of a diabetes application, which again, this is one of the opportunities that came out of having to stay away from each other. So the application was developed, first of its kind in the Caribbean, first of its kind in Trinidad and Tobago, definitely. And it allows persons, it's going to come out this week, and it actually allows persons to enter their blood sugars, enter their other parameters. It tells you if it's too high or low. It sends messages to physicians. It sends messages to next of kin if something is too low, dangerously out of range. It allows you to have it allows you to have and show physician time range. You can make donations to the association. You could become a member of the association. You could access an online store. You could get diabetes education information on it. And there are a host of other features on the application. So we've curated all of the features that we've wanted for persons living with diabetes to make their lives easier, or to help care for them better. So of course, this application is one of the things that we are launching. It's called DAT app, DATTAPP, and it's going to be available on both Apple and Google Play stores soon. Another project that we've started some time ago with partnership with the Trinidad Eye Hospital is our diabetes eye screening program. We wanted to reach 400 persons this month, screened for diabetes retinopathy or any other diabetes eye disease. And we did that, and we went into 10 communities. On Monday, we were in Tobago, tomorrow we're in Moruga, and by the end of next week, we would have reached over 400 persons who would have never had those types of tests before. At the end of it, we're now going to be able to see, well, out of those 400 persons, how many did we actually detect? How many persons did we actually find that would have had some sort of problem that would have resulted in blindness? So that now we have to present. We're gonna apply for grants afterwards so that we could actually expand that program. And of course, that was free of charge to persons. So that's one of the programs that we have launched, and we're going to continue doing that at our head office after the month of November. The Diabetes Association is also being on screening. So as I said, the Diabetes Eye program that we were doing with Eye Hospital, but we also launched last year the Know Your A1C program, because of course, for persons with diabetes, the HbA1c test is the most important test for diabetes control. It is the most important test management, but also for persons who may want to know if they may be at risk of prediabetes. I would argue that it's important for screening as well. And it has been quite expensive and inaccessible because we haven't been using point of care testing. But of course, last year, the association was able to secure machines, point of care testing machines, and we would have launched the Know Your A1C program. We teamed up with the Lions Clubs of Trinidad and Tobago, and we trained about 200 persons, teaching them how to do HbA1c testing. And we would have gone in communities doing the A1C testing. And most recently, we trained a batch of student nurses who, that's why they're wearing masks, because of course it's a recent picture. But we trained a batch of student nurses who would have been able to now go into some of our branches and also be at our head office and conduct HbA1c testing. Of course, HbA1c testing is pretty expensive still, but we do offer it at the price of $80 for a test, which of course a lot of persons come for, and they get the results in 3 minutes. So that test is available, and of course we are asking persons to come. Everyone who is living with diabetes should have it as regularly as they can, at least every 3 months. And everyone who is over the age of 30 should have it at least once a year. So at least we will be able to know what's going on. So that's the A1C. And of course, we have lipid profile testing at the office and random blood sugars. Most recently, and Professor Narayan Singh would be happy about this, is that we're about to launch a diabetes foot screening program. Because of course it's very and this is actually something that came out of our webinar on Sunday, where we had panelists from the UK, a podiatrist from the UK, and we did polls during the panel. We did polls during the session, and the participants who asked the question, are they afraid to go seek out foot care? And many of those persons did say that they were afraid to go seek out foot care, because for many persons in Trinidad, they're afraid that they'll get the foot cut off. So for many persons in Trinidad, they don't want to go to see the doctor because they might think, well, they'll cut off my foot, and the longer I can keep my foot, the better for me. But of course, as Professor Narayan Singh would be saying, it's that's not the right way to do it. So we have teamed up with some podiatrists, and we're actually trying to develop a program whereby we could have the same student nurses go out onto the field and do preliminary foot screening, just preliminary foot screening, where you could just look at the foot, probably use the monofilament, and we're looking into some sort of tools where we could just have that basic screening, where we go to the persons around Trinidad and Tobago, and then we could direct them and say, okay, here, there is a problem, we could detect it a little bit early, and then direct them to where they need help. And that's where the association is coming in, because we are going to the persons that need the help the most. So we've started this a couple of weeks ago, and Monday we did have 15 persons at our head office who came to us and got that foot screening. And then of course we do want to have that training program so we could send these people out into the field and do that. So that's a program that we're about to launch soon. And of course, just to bring home the message, I just wanted to talk about the prevalence of diabetes, because of course, this is the reason why we are doing this type of work, and this is the reason why the work is so important. In the world today, we may have about 400 million persons living with diabetes. And of course, we estimate that in 15 to 20 years, this may increase by 200 million more. What's more relevant to us, again, is what's happening in Trinidad and Tobago. And I was trying to look for the history of diabetes research in Trinidad, the history of prevalence. The earliest recorded paper that we could have found was the Poon King paper, where a prevalence of 2% was reported. Now this is in the late 60s. So in the late 60s, about 50 years ago, or a little bit more than 50 years ago, we had a prevalence of about 2% in Trinidad and Tobago. In 96, there was another study that we found about 11% prevalence rate. So the prevalence increased. In 2012, the STEP survey was done. Well, this was done in 2011, but reported in 2012. And a prevalence of about 13% was reported. And on top of that, 20% impaired glucose pre-diabetes. So at that point in time, the estimate is about 33% of persons living with diabetes or pre-diabetes. In 2019, 2020, the IDF estimates, and again, this is estimations and projections because no solid type of research has been done since. The estimation is between 13 to 16% prevalence, which puts us at about 200,000 persons in Trinidad and Tobago living with diabetes. When we look at impaired glucose tolerance or pre-diabetes, that's 20 to 25% on top, so that's 300,000 more. So these 300,000 more people are the people that we want to target. These are the people who have pre-diabetes. These are the people who we could have interventions targeted at them. These are the people who could prevent from developing or slowing down the progression of diabetes. And this is why the work of the association is so important, because as we know, as Professor Narayan Singh would have shown, the amount of money spent just on foot alone. So imagine for everything else. We spend the most money on any other disease. Diabetes ranks the number one, is the number one spend of the Ministry of Health. Diabetes is the number one cause of hospital admittance, or number one cause of beds occupied, and the most amount of beds occupied are persons living with diabetes. So of course, the problem is huge, and the Minister of Health always says that diabetes has the ability to bankrupt the country, because of course the spend is going to be so huge if we need to treat with these people. So what may have to happen is either we don't treat them as they should be treated, or as well as they should be treated, and that they suffer, or we get bankrupt because we don't have the money. So I don't want any of those situations to happen. So of course we need to do the work now. And I mean, we've been preaching for years, but you know, through the Ministry of Health, they actually are putting in a lot more money into the organization and into the work, through the TT Moves project, through the HSSP loan. So we are trying to tap into that and do a lot more work with the association and the things that we would do, the projects that we would have had planned. I also mentioned, well, I think Dr. Rambran would have mentioned the types of diabetes, but what's also very startling and parts of my research is looking at diabetes in children, because of course in Poon King's day, he was able to find 2 children in the whole country with diabetes. Of course, now we have many more children with pre-diabetes, and the association has launched diabetes camps and child lifestyle camps, or teen lifestyle camps, where we work with children who are overweight or obese and teach them about nutrition and exercise and stress management. And we started that last year. Unfortunately, we couldn't do it this year. This year we did a virtual camp for children with type 1 diabetes. But hopefully next year we can do it in person, or multiple in-person camps for those overweight children. This was a study that I was a part of a while ago. Well, actually, it's 2014, where we looked at how prevalent obesity was in schools. And what we did find, we surveyed 300 students with the Trinidad and Tobago Olympic Committee, and when that survey was done, we found 1 in 3 children were either overweight or obese. When we compare those statistics to children in the United States, from first year up to standard 5, and Trinidad is in that red line on top, that 95th percentile compared to the reports from the CDC in the United States. At every age group, our children in Trinidad and Tobago are heavier or fatter than children in the United States. So it tells us something, and it tells us it's a bad omen. And this is 6 years ago. So we need to get the data now. So this is the type of research that the organization is doing, this type of prevalence, this type of epidemiological research. So we hope to get some more recent data to see what is happening, because we need to stop it. Just on a point to note about sugar, because of course a lot of people talk about sugar and diabetes, and of course the misconception is sugar causes diabetes directly, but really indirectly it causes obesity, or excess sugar will cause obesity, which will cause the diabetes. But we do know that sugar indirectly would cause diabetes, or excess cause. Every time people think of diabetes, the first thing that comes on their mind is sugar. So we do work with persons to sensitize them about sugar, and particularly sugar-sweetened beverages. So sugar-sweetened beverages are the #1 cause of excess sugar or excess calories in our diet. One survey was actually done a few years ago, and the Healthy Caribbean Coalition reported that of all the countries in the world, Trinidad and Tobago consumed the most sugar-sweetened beverages per capita than anywhere else. And this actually ranked 2.5 times more. So we consume 2.5 times more than other Caribbean countries. So we consume way more sugar-sweetened beverages than we should. And of course, this is the source of excess calories, and it may be one of the driving forces of obesity. So this is why we work with the Ministry of Health to ban sugar-sweetened beverages in schools. Of course, we still have to see the effect of that, and the effect has been subtle, but there's a lot more work to be done. So with that, that's one of the pieces of work the association has been doing. And in closing, of course, I just want to leave you with a message that people who may not think that they should get screened should get screened, and we are asking everyone out there to reach out to the association. I'll give the number at the end, or phone number at the end, but you could also reach out to us on our Facebook pages or Instagram pages, and message us on any time. And we have those facilities available to you, because even if you don't think that you may be at risk or you may have a problem, you may just have a problem. And the reason I'm showing this picture is because the moral of this story is 100 years ago, this man would have walked down the street and everybody would have turned their head, because no one else looked like him. So Big Joe, 100 years ago, was the biggest man in the world, or biggest man at that point in time. No one else was like that, was like him. So of course, if it is that he saw, or if someone saw him, they would know that something is wrong with this man. But of course, today, people like that are ubiquitous. They're all over the place. And if everybody looks the same and it becomes normalized, then people no longer check themselves. They no longer think they might have a problem, because of course, everybody looks the same, everybody looks the same. So this is why, even though you think you might be good, you should always check yourself. And we always say, if you're overweight, or if it is that you are over the age of 30, come to the association and get an HbA1c test, and let's see what's going on with you. And of course, it's in Trinidad as well, not just all around the world. So with that, thanks again for having me. And I do want to just leave this link on the screen, ticketbay.com/d/DATT, where anyone could go on and make a donation to the association. And of course, the money that we get here is what we use for educational projects and our screening projects. So we do need that support. So with that, Dr. Glasgow, thank you. I'll turn it back over to you.
Thank you, Mr. Danu, for reminding us of the need to serve and support your organization's critical work and reach. I am pleased to point out, though, that I was one of those 500 persons who viewed the Carlton Phillips webinar on Sunday, and I must say that I found the event to be informative, as was your presentation this evening, particularly as it served to reinforce Professors Narayan Singh's and Dr. Rambaran's discussions. And so I urge our viewers to access the recording on the Diabetes Association Facebook page on Sunday's webinar, and to become involved in the other events carded for this month. And I'm also eagerly awaiting the app launch. At this time, I would now invite our panelists to give further comments on their work or on the work of their colleagues. And anybody can start. Yes, of course you can start, Professor.
Because the time was short, of course, I couldn't cover a whole lot. And I just want to make two important points, I think. One is, we have in Trinidad and Tobago, fortunately, almost every facility we need to do good limb salvage. That's the first point. The second point is, I've actually calculated that if we are really aggressive about it, we could save about 80 to 90% of the limbs that we actually lose. And that's a phenomenal amount considering that we lose about 500 per year. So those are two important points from my point of view.
Professor, what would you say then are the barriers towards salvaging limbs, if we have the capacity to do so?
Barriers are, one is education. People are really unaware. As Andrew said, a lot of people are afraid to go to the doctor, that they're going to lose their leg. And we do, I did make that point. We published a paper on that about the delay incurring increasing cost and increasing risk of limb loss. So one is education, and education is, Andrew and they seem to be doing a fantastic job, but patients are really still unaware, and they await a catastrophic event before they really take it on seriously. When they lose a limb or they lose sight in an eye, then they start to get serious about their sugar, which is perhaps a little too late. So one is education. Second is, as you saw on those pictures about the feet, it's easy to underestimate the extent of sepsis. Is rotting below the skin, and the skin looks so perfectly normal. So even the nurse or doctor or surgeon has to have a high index of suspicion in actually making this diagnosis. I tell you, up to now, I've done this for so long, I still don't know when I'm going into a foot, like if I'm going into a rotten zabuka, how much of the zabuka is gone. So it's as deceptive as that. So that's another side of it. And the other thing, of course, is foot care. You saw the amount of trauma, the trauma from getting choked, getting cut, getting rat bites, getting hot water burns, all sorts of trauma. And it's in an insensate foot. It is easy to traumatize it. It has absolutely no sensation. They can walk on hot coals or not know. So those are the essential things. But all the facilities are available in Trinidad. We can measure blood flows. We can do bypass. There's a new surgeon back who is doing phenomenal work on endovascular, doing angioplasties and stenting on peripheral vessels and so on. So a lot of good things are taking place.
Thank you, Professor. Dr. Rambaran, do you want to add?
I just had a question for Dr. Narayan Singh, Professor Narayan Singh, sorry. That case with the patient that had the rat bites on his foot. was there any sort of reason, suspected reason that the rats would have gone? Probably because would have done this, but because the foot was rotting, or there was some scent or something like that that would have caused, or is that just by chance that it was bitten?
The rats actually, for some reason, and this, we are not the first people, we actually published in the American Medical Journal. We had a couple of cases. The rats somehow sense that it is a sweet foot, interestingly, and they feed on it. And the patient is asleep and not knowing that the foot is a target.
Yeah,
and
that's why I asked the question, because in the history of diabetes, that is how they initially picked it up in terms of urine, because ants, when people would have urinated, ants would come toward the urine because of the sugar in the urine. So that is why I asked that question. Interesting, very interesting.
Mr. Danu?
Well, just to add on the trend of talking about foot care, and it's very interesting to note or see all of the cases that Professor Narayan Singh would have presented, and how, again, it goes to show how much of an effect people, or how much diabetes affects persons, and it really is only when you do get a catastrophic event, or really when you do have the problem gone way past no point of return, do you really have that intervention, or do you really seek medical care? And this is why screening is so important, because of course, if we do have screening, not just HbA1c screening, but foot screening, retinopathy screening, and we do have these screenings very early on, then we could detect these problems. And of course, detection would mean that it could be early enough to treat it and salvage it. And of course, this is why it's so important, and this is why we have been pushing it. Professor Narayan Singh also spoke about education, and education is so important. And again, not just education about diabetes in general, or what it does or what it can do, because that seems to have been what education was for a long time. What is going to happen to you? Your foot will get cut off. And that's basically what doctors have been telling patients forever. And that has not worked to deter them from doing what they should do, because they would think about it as though this is something that could happen to me in 10 years, 15 years, or never. So we have seen that not working. And of course, doctors even tell children that, because children with pre-diabetes or overweight children, you would try to scare them into submission, but it doesn't work. You have to tell them what they should do and how they should do it, which is most important. And that's the type of education that I think we need to push, to really meet people where they are, and not just give them the information. One example that we are always faced with in terms of nutrition is almost every person who has been newly diagnosed and come to us would ask for a diet sheet. A sheet that would tell them a magic recipe to tell them how they should eat. But of course, there's no magic recipe. There's no diet sheet, and that used to be a thing a long time ago, where a nutritionist or someone in the hospital will give you a photocopied piece of paper that would list the things that you shouldn't have. But of course, you don't know what you should have or how you should have it. So that's why, of course, we need, and what is most important is a multidisciplinary approach to treating diabetes. You can't just work with a physician. You need to work with diabetes educators, which are most important, and there are many diabetes educators trained in Trinidad and Tobago who are nurses, Caribbean certified diabetes educators, and we're not using them. These are the persons that we need to use to educate persons in communities. We need to be working in conjunction with the podiatrists and the ophthalmologists, and we need to have this multidisciplinary approach to diabetes care, which of course the most places in most developed countries have mastered, and we are trying to catch up with. But I think we need to push that a little bit more. And yeah.
Andrew, while you're on the topic of diet, could you comment and give some clarification on the glycemic index and the foods like this? Because there was a presentation that I was part of. I was in the audience, and the person was talking about pumpkin. Dairy from pumpkin is very high in the glycemic index. It's not good for diabetics. And then there's another contradiction. And then I went home and I told my family, I stay away from that, right? But then I was reading up some more, and then there's a contradiction to that in terms of the, I think it's the availability, or if you don't mind, just speak a little more on that.
Okay, so yes, and the glycemic index does indicate how quickly the blood sugar, or how quickly sugars are going to be absorbed into the bloodstream. And different types of foods would have different ranges, and of course, we do gauge it based on glucose absorption. So when we do a glycemic index test, and of course, it's interesting that you note that, because I've been looking in Trinidad to see if anyone has ever done glycemic index testing on foods. There's a product that the association has started to work with for persons with diabetes, and I had to look at the protocol, and I conducted glycemic index testing on persons. And of course, the protocol is whereby you use persons, and you do an oral glucose tolerance test on them, and then you use similar concentrations of available carbohydrates. But the thing about it is that for many persons, or many foods in Trinidad and Tobago, we may not understand how quickly the sugar gets into the blood. Pumpkin and chana and dal and those things that many of us like to eat actually raise blood sugars pretty quickly. And for many persons, they may not realize it, and they may just think that eating sugar alone is what is going to raise their blood sugar. And it's interesting to know that you would have found contradictions about pumpkin, because of course a lot of research is out there about many things, but in general, pumpkin does raise your blood sugar because the glycemic index is pretty high compared to some of the other foods.
So if I could just interject at that point, because I wanted to pick back up. The contradiction wasn't actually against pumpkin in terms of the glycemic index, but now the contradiction is that you can have it, but in proportion, or in portion size. So then portion control along with the glycemic index, so it allows the people to have the cake and eat it too.
Yes. So glycemic indices are made, well, are determined for specific types of foods or specific types of ingredients. But we don't have glycemic indices for meals, which of course is the combination of some of those foods. So of course, if it is you have the pumpkin and you have something high fiber together with the pumpkin, it's going to reduce how fast the sugar is absorbed into the bloodstream. And again, this is why it's so important to have a nutritionist speak with persons with diabetes rather than just giving them a blank diet sheet or a general diet sheet. So the combination of foods and the way that you combine those foods, and we always tell persons, because when they all ask us for a diet sheet and they ask us, oh, what is a diabetic diet? There's no diabetic diet. There's nothing that you cannot eat as a diabetic. You could have anything that you want. But again, it's the proportions that you have. And you need to learn what those proportions are. And it isn't hard to teach. It takes a little while to teach, but once you do invest a little bit of time with a patient, you can teach them what those proportions are and how they could easily manage it.
Thank you very much, Mr. Danu. And I must say that I'm happy to hear this information this evening, although I'm quite disappointed that I have to manage my portions of pumpkin. But I would now turn to our last segment for this evening. A question is coming from Cyril Collier, and he's directing this question to Professor Narain. And Cyril is asking, is it advisable for diabetics to sleep with socks on? Professor Narain, unmute. Thank you.
Sorry, yeah. I don't think that matters. The socks doesn't do anything of value. So I don't think it offers any protection. That's a simple, short answer to that.
Thank you very much, Professor. This question is directed to Dr. Rambaran. Javed Mohammed is asking, what is the efficacy of vanadium compound as compared to synthetic insulin in controlling blood glucose levels?
So the mechanisms between vanadium and insulin are two totally different things, as I would have explained when I showed you the insulin transduction pathway. In terms of efficacy, vanadium, if overdosed, will induce hypoglycemia. So in the same way that you would take, and we use vanadium and its associated complexes for therapeutic reasons, right? The biochemistry of our bodies to secrete insulin on a regular glucose detection rate is something that is built into our system. So it depends on the dosage, and it also depends on the nature of the drug that is administered in terms of the vanadium complexes. So as I would have mentioned, those in my discussion, those previous complexes that were presented before from different researchers, they had different degrees of efficacy based on the nature of the ligand being that organic moiety that's stuck onto the vanadium ion. This particular ligand that I ended up working with gave such unique and outstanding displays of anti-glycemic or anti-diabetic activities that it allowed us to run a dosage of 1 in every 5 days. If we put it 1 in every day, it is possible that we could actually induce hypoglycemia if not monitored properly. So all of these things are now in testing phase. We just want to test the toxicity of this drug, of this particular drug, and the others that I'm working with. And then when it goes into human trials, then only then we can do double-blind studies with other commercially available drugs, with insulin in terms of different dosages, and then a proper dosage regime can be determined if it gets to that point, of course.
Thank you, Dr. Rambaran. Question from Chrissy Berry for Professor Narayan Singh. Can you explain the relationship between blood sugar readings at a sustained high level and gangrene, as well as vascular health?
But that's diabetes. Diabetes is sustained blood sugar levels at a high level, or uncontrolled diabetes. Of course, uncontrolled diabetes will facilitate the spread of sepsis and will make the patient more prone to infections generally. And of course, it's worse with trauma to the foot. Now, a lot of the septic feet we see do not have an impaired blood supply. What they have is impaired sensation, and they have an impaired ability to fight infections. And poor blood sugar control worsens that. The other thing that poor blood sugar control does is that it worsens the blood supply over time. In other words, if you have poor blood sugar control, your blood vessels deteriorate more rapidly. It's like having salt water in a pipe over a period of time. The less the salinity, the less rust. So that's a simple way to explain to people that they should control the sugar to preserve their blood vessels.
Thank you, Professor. And then we have one final question for Dr. Rambaran. In what year would PDOV be available on the market? And what are the side effects of PDOV, PYTOV, and who would be the best candidates for either treatment?
Okay. That question is based on a lot of ambition and sponsorship. And I'll tell you why. Thus far, I have reached this level of my work with a lot of personal sacrifices and yes, some support from UTT and other grant agencies. But as we go to the other levels of study, especially the year 2, and this is even preclinical studies. Right now, we need sponsorship. We need sponsors, not necessarily investors at this point, looking at the benefits of developing such a drug to enter human trials. So we already projected, and all of our studies have been that I projected to do was peer reviewed and evaluated by some of the top scientists in the world in the International Center for Genetic Engineering and Biotechnology. So they were deemed to be valid, and it is supporting our ambition to go into human trials. So we need to complete those 3 years of preclinical studies. And depending on the data from that point, now we need to understand as well, there's still no guarantee that whatever is safe in a rodent will be safe in a human, right? But it gives some sort of assurance. Yes, it gives some level of assurance that when we go into human trials, we are going to be wasting our time. And then we can project from the dosages that we would have evaluated at the rodent level now to that of a human. Now, for some strange reason, I have no idea, we could call it a conspiracy theory, I have no idea how in a pandemic we could have had a virus and a vaccine released in the same year. Vaccines, anything to pass through human trials takes about 10 years to get approved through the FDA. And I'm sure Professor Narayansing, I'll welcome him to confirm this. So at the end of 3 years, then we have 3 more years to go through ambitiously with sponsorship. And this is where human trials, we're talking about in millions of US dollars to go into human trials. And this is where we need the sponsors and the investors. Once you go human trials, you can look at investors. And at the end of those 3 years in human trials, then and only then we can make the application to the FDA for the commercialization of this drug. So we are looking, if all goes well, best case scenario, I will say about 7 years from now. Best case scenario. But again, I'm glad that a person asked that question because it allows me to open the eyes of the public that this is now a venture for Trinidad and Tobago. This is an opportunity to put us on the map for something that has not been done before. And to reach this level, to get a US patent, right? It says a lot for the potential of this drug. To have the prior work to be evaluated and have people shaking their heads. It says a lot that there's promise for this, but we cannot go any further without the financial assistance. So Professor Narayansing, can you at this point just confirm this for me, please, in terms of how long it will take for something to pass through get up FDA approval?
Professor Narayansing.
Of course, it varies from drug to drug and so on, but it is a slow process. What you're saying is absolutely correct. And so that's why it's so good that somebody as young as you starting it so that you can see it through. It's good to have to start early in your career pursuing something like that. And I want to congratulate you.
Thank you, sir.
Thank you, viewing audience, for your questions. Thank you, panelists. I must draw the curtain down on this evening's discussions, and I'm sure that you would all agree that it has been certainly an informative one. I wish to thank our panelists, Professor Vijay Narayansing, Dr. Varma Rambaran, and Mr. Andrew Danu for sharing with us their expertise and experience as it relates to diabetes research. My interest was particularly piqued by Professor Narayansing's discussion on the prevalence of amputations and why diabetics lose their feet, Mr. Rambaran's riveting research in the area of Vanadium complexes and the likely impact on the diagnosis and care of diabetic patients, and especially the opportunity for Trinidad and Tobago to be a leader in this regard, were well appreciated. Mr. Danu's presentation on the significance and relevance of his work and the work of the association as they continue to support the diabetic population in our nation was for me an eye-opener. On behalf of Professor Prakesh Prasad, Vice President of the Research, Academic and Student Affairs and Acting President of the UTT, and our Board of Governors at the university, I wish to thank the members of the panel for making themselves available to share their knowledge and expertise with us. Thank you, the viewing audience, for your participation, and I hope that you will continue to participate and engage in dialogue geared towards stimulating health and well-being awareness as it relates to diabetes. Until next time, stay safe and good evening.